Hello friends, today we have a patient who has critical stenosis of the carotid on the left and very significant stenosis on the right carotid, and symptoms of multiple transient ischemic attack, this means stroke. We are going to do angioplasty and stenting of the left carotid artery with distal embolic protection. So we will see how to do this procedure, because this is very tricky because bilateral carotid artery is significantly stenosed, and that the one that we are doing today, the left side, is really critically stenosed. As we during the course of the procedure we will come to know that. So with me we have Dr. Ganesh today. You can show your face a little bit. So Dr. Ganesh, and we have Parvati, who will be assisting me, and we have Prasad, and of course we have Gauri and the other staffs. Thank you. Quite back. So it's a nice afternoon, 2 o'clock. We have loaded the patient with double antiplatelet a couple of hours back. And we have taken a common femoral artery on the right side, it's a puncture. We can also do radial. After the puncture, we have given 3000 heparin IV, lateral piece. So Dr. Ganesh works with us in emergency and looks after stroke. So we thought it is prudent that he understands how this disease is treated. So we will do a digital subtraction angiogram of the carotid. So you can see it's very, very critical here.
Yes.
So this is a 99.9% stenosis. So this is what we are going to treat. So let me take another run. Just give me a mag. Table, please. All right. So you can see it very clearly now. We can give you a frame. It's 99% stenosis, and this is the beauty of the procedure. It is done under local anesthesia. Patient is completely awake and is able to talk and ready for an neurological examinations. Put me on that. So basically there are two procedures that is done for critical carotid stenosis. One is a surgical procedure, that is a carotid endarterectomy. The other one is a non-surgical, that's a carotid artery stenting, which we are doing now. Contrast.
So what is the success rate of this procedure, sir?
For us it is 99%. We have been doing carotid stenting since 2006. I have treated more than 1500 carotid stents.
Okay.
That also distributions. So by grace of Almighty, we have close to zero complication doing this procedure.
Yes, sir.
And they are quite strongly following with us,
Yes, sir.
because we will be able to do a Doppler anytime we like.
Yes.
So we do a ultrasound Doppler follow whenever we have a doubt or even in a routine setup. So we have a complete follow-up of set of patients with us. Boycott garu ella unnaru? Huh? Okay. Brought my pouch. Brought Mac copy. No. So we are taking our అయిపోయిందండి ఇంకా అండి. So one has to be very gentle and can happen. What is it? Paraji? This one. So Paro is an excellent assistant who is with us for more than 10 years. So she's quite knowledgeable. Heavy please. Kadalu, chala baga. All right. We have done the cerebral angiogram yesterday to understand how the things are. So we will now take a distal embolic protection which we will put across the lesion so that in case you have any kind of thrombus going from the site of stenosis, it will not be allowed to the brain. So we will hold it before it reaches the brain. Let's look at the distal embolic protection jar. This is Embosil we are using today. So important for us to make it tear free. So it's important for us to take the gold marker all the way to the black marker. Just remove the whole system which is ready for deployment. Get ready. So we'll give a little scene. So we try to give a gentle J so that navigation could be easier. It's going to be a little challenging to navigate inside the critically senosed ICA here. We'll try our best. Should be okay. That's the question. Pneumodipin pressure చూడండి. All right. So we are going inside. So meanwhile, if you want, we can take a cerebral angiogram for you to see how the circulation before the stenting. Can you please cover the head? Cover the head. Cover the head. Good. Table down a bit. Right. So this is the angiogram. It looks so very seriously hypoperfused. Now show me the carotid pressure. Carotid to be 10%. Mag. Colmate side to side, table up. One more mag. Road map. So now we'll try to navigate this. Kadaladu, why could Oh,
Yes.
that's the shape which has taken our filter right there where we want it. So God is kind, we are through. So we take to the high cervical opitrus. We have good length between the area to be stented and the filter that has to be placed. So I'll be happy to place the filter over here. And I will deploy the filter. You can see this. This is called a filter or an umbrella device. I'm going to deploy it. It's deployed. Can you see that?
Yes, sir.
This umbrella opened. What? So we have deployed the umbrella device that is called the distal embolic protection, and today we've used an F6. We can use a spider or we can use a filter wire from Boston. We prefer this one. So, Dr. Ganesh, you have any questions?
Yes, sir. Like this seems so easy, but it's not very easy to do so because you have so much of experience
So
that you can do it.
16 years of experience,
Yes.
more than 1,500 cases, so it's like it looks easy.
Yes, sir.
And the most important thing is that you just have to have a cool head over his shoulders. So everything is okay.
So how often do you do these cases, sir, on a regular basis?
See, I mean, we have basically, the first most important thing is the right workup. We have done a cerebral angiogram of this patient because the patient has multiple TIAs, and met our neurologist friend, Dr. Salesh Modi, and who investigated the patient thoroughly and did an angiogram, 3D angiogram, and found these blocks. The patient came to us, and then we investigated with a DS angiogram, and that gave us the entire picture of the cerebral and the neck vessels. So we know what to expect. Then your stress level is less, your preparations is better.
Yes, sir.
And then you have friend like, there is Ganesh inside, then you are more comfortable. So we make the we make automatically 2.5. 2.5. So now we can see there's a beautifully placed distal embolic protection in the high cervical region. We have good length of carotid left for us to do the angioplasty and stenting. Now the angioplasty, stent deployment, and post-stent angioplasty, if required, they all will be, if at all there is a kind of thrombus going up, it will be caught, and we are in a good position to go at perpendicular. Yeah. So we will do a little bit of dilatation to the lesion with a 2.5 into it's about 14 millimeter, so that the stent is going smoothly. And post deployment of stent, if required, then we can do a little bit of angioplasty. So now the question can be like, what could be the issue if you have carotid artery disease, or how to diagnose, or how to identify? Now typically there are two carotids which are responsible for supplying the blood from the heart through the neck into the brain. They are called carotid artery. We have one on the left, one on the right. The carotid artery, or the common carotid artery, as it goes through the neck, it will divide into two. One goes to the face, which is called an external carotid artery. The other one goes to the brain, which is called an internal carotid artery. Now, if there is a stenosis or narrowing of the internal carotid artery, obviously the blood going to the brain, 2.2512, yes, good size. So, yeah. So we will do a T-plasty. So in case we are having a carotid artery disease, obviously the blood supply distal to the lesion is less. So, there can be the symptoms which are starting. So if there is a plaque which is ruptured, the carotid gets blocked, patient gets a stroke. If there is a small plaque which is further from the lesion, goes to the brain and occludes a small little vessel, we can get a transient ischemic attack, or we can get a laminar infarct in the imaging. So these are the symptoms. Suddenly a patient is having the signs of stroke or mini stroke, that is TIA, or sudden loss of vision, which he or she regains back, which is called amelosus pigad. So 3 sets of symptoms if are there, you should think that I should look at the carotid. First, patient is having the symptom of mini stroke. Second, the loss of vision, which is reversible, or the patient is having a full-blown stroke. These are things where we look at carotids.
Sir, are there any contraindications to do this, sir?
Sorry, yes, please.
Are there any contraindications to do this procedure, or
Yeah, so there are always contraindications to any procedure. They may be minimal, but there are some. Like for example, if a patient is allergic to contrast,
okay.
then we cannot do the procedure. First. Second, suppose the patient cannot be put into antiplatelets, then we cannot do the procedure. Then, if you have excess site, excess site issue, like there is a groin issue, aortobiliac occlusion, those were relative contraindication because we are doing now transradial.
Yes.
And so these are the things. Go ahead, please. So, a little bit of dilatation to the lesion so that the stent goes freely. Yeah, different. So this has to be a quick inflation and deflation. We don't want to save the neuro. Okay. So we don't want to keep it inflated. That's not required or recommended. Two is perfectly fine for us. So we go ahead with the stent. Careful, Para. Roll me about. सीधा देखो. हाँ. Close your eyes indeed. Very good. Come here. Come here. Excellent. So the question here can be also some other questions, like now this patient is having carotid artery stenosis in both the sides. Are we going to do the stent of both carotids at the same go? The answer is no. We are not going to treat at the same go. That's not recommended because we don't want to open a floodgate. Can I have a stent? Yeah. So we don't want to have a floodgate opening and very so circulation should open slowly. Stop.
Sir, what is the hospital stay required for this to do this, sir?
Yeah. The hospital stay is 2 days. Typically, the patient is admitted today, the procedure will be done today, and tomorrow will also be able to do the stuff.
Okay. So it is minimally invasive as well as minimal hospital stay.
Minimal hospital stay, 2 nights stay. One night is the day of procedure, other night is the day of observation, the other night goes home.
Okay, sir.
So we are choosing exact 6840.
కదలదు పైకి చూడండి.
Close your eyes.
కళ్ళు మూసుకోండి.
Close your eyes. Okay. ఒక 2 minutes అయిపోతుంది. Close your eyes. So we are navigating the scan. So we are taking the stent now. So we used a Neuromax to place the stent here. So this will be a good position for us. So we can check, but we might not get any flow because the stent might have just occluded the carotid here. So I may not be very keen to do an injection, which is not necessary here. Roadmap out, better. Yeah. Okay, we have just covered enough. So we are going to. So I'm deploying the stent. All right, so we have deployed the stent. So the stent is beautifully placed at the lesion. It has to be placed at the middle of the lesion. This middle of the stent is placed. So now I'm taking the relaxing. Carotid has been given.
Yes, sir.
This is a little tricky here. I have to navigate the dial because this was holding it. Now I can. So perfect. Coming up for it. So we are removing the stent delivery system. So we will go with the post-validation. So Ganesh, are you able to follow the things?
Yes, sir, I'm able to follow the things. Coupled with your great explanations, I'm able to understand everything what I'm saying.
So things are looking perfectly fine. We can do a balloon angioplasty of that stent to improve the caliber a bit. Can I have a balloon? Huh? 520 balloon we will take. We will just open up the stent a little bit. So what are the signs of stroke? So basically the stroke can be of two different types. One is because of the rupture of a blood vessel in the brain, which is called a hemorrhagic stroke. And one is because of the occlusion of a blood vessel, which is called an ischemic stroke. Ischemic stroke is by far a very common cause of stroke. Common type of stroke is about 85%, 15% only hemorrhagic stroke. So whenever a patient is having an acute ischemic stroke, then to remember, we should remember as be fast. So F for facial weakness, and A for arm weakness, S for speech weakness, and the loss of balance and eye symptom for VE. So these are the symptoms for a patient. Is that to tell you that he is experiencing a stroke, and you should rush to the nearby stroke center because excellent treatment for strokes are nowadays available. In terms of thrombolysis, if it is within 4.5 hours, and thrombectomy, if it is a large vessel occlusion, right from the onset of stroke up to 24 hours in some cases. Hold. Round my mouth. One mag. So we have a distal embolic protection placed there. We have a stent across the lesion. Now we have a balloon. Go ahead. Stop. Stop. Deflect. Come here. Got it. Got it.
Okay.
There. Okay, check. Next. 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 Deflect. So don't try to match all the way to the carotid. You should inflate just enough. All right, all right, all right, all right. Patient can have some symptoms because of the vasovagal
Okay, uncle.
symptoms. You just have to be careful about it. Don't try to overdo things. There it is. All right. So the idea of doing a carotid stent is to match 80% of the possible original size. Don't try to make it 100% because you have a chance to dissect the vessel or rupture the vessel. DSL. All right, looks perfectly all right. Good flow. We will show you the DSA once the patient is a little stable. You're just moving a lot. Everything is stable, everything is okay.
So how early can you do this procedure? So like once from the onset of stroke, like what is the earliest
That's a very
time?
good question. Like what is an indication to do carotid artery stenting? First of all, we should understand that if a carotid is stenosed by 70% area stenosis or more, that's an indication for treatment, even if it is symptomatic or not. Or if it is 60% or more with a symptom on the same side, you should also treat this patient. So 70% with or without symptoms, 60% with symptom are the area indications for carotid artery stenosis to be stented or to be done with the CEA. And how soon we can do? Suppose you have a patient who has a stroke. So if it is a major stroke, you should wait for. So you have a right carotid critical stenosis, the flow is still there, 99% stenosis, patient had a stroke, massive stroke, you have to do the carotid stenting after 6 weeks. If it is a minor stroke, you can do it immediately. So these are the indications for time and the area stenosis. We'll do another small gentle session at the couch. Go. Go. Deflect. ये sound पार्वती का जो sound है ना, that is terrific. So we will stop here. So we will look at it at another angle. So very flexible, very mobile segment. Can we look at LIO? Wow, perfectly okay. All right, Ganesh?
Yes, sir.
Now we will look at the cerebral angiogram, what changes we could make. Epicranial. Table. Beautiful. So
Yes.
the ACA were not seen. We can show you the before and after picture here. Can you show the before angiogram AP, cerebral? Go to the neck, so that's straight angiogram. Go back. Go back to 1, 2, go. Perfect. Go. Go down. Series number 18. Go to 18. Next. Yeah. Yeah. So this is the angiogram. Just go back. Stop. So this is the angiogram before the carotid stenting was done. Save it here. So this is the image we have taken on 4th of April at 6:58 p.m. That is yesterday. Today after stenting. So now angiogram. Now angiogram. Yeah. Stop. Now you can see the difference. See the AC, antecerebral artery, has completely come off, the A1, A2 and everything. And the circulation at the MCA region also improved. That's a fantastic way of comparing what the carotid stenting has done to this patient, and patient is absolutely fine. Boycott garu ella unnaru పేరు చెప్పండి. Excellent, wonderful. So now go to the lab, we will remove the filter. So we have clearly demonstrated how this stenting has improved the cerebral circulation. So this is going to improve a long way in terms of cognition. And of course we have prevented stroke, which could have originated from the carotid because of this critical stenosis. Beyond the prevention of stroke, there will be many more benefits because of excellent revascularization of the cerebral circulation that we see. So we will remove the filter now, very important step. So this is the 4th April 6:58 p.m. This is the 5th April 2:36 p.m. This is before the carotid stent, the cerebral circulation. This is after the carotid stent is being done. So we remove the filter, table please. Mag, all it side. Table please. All right. So we are going to retrieve the carotid filter. So we have to capture it so very carefully. Table please. All right. Table please. All right. So we are trying to catch the filter here. See, we have captured the filter as much as is needed. And brought it down. So we don't try to capture the filter fully because it might squeeze whatever particles that could have been there. So we can check and examine this. So this is the filter. Some little particles. Some cholesterol particles are chill. What do you say, Ganesh?
Yes, sir.
So that has been captured.
Yes.
We don't see a mega clot like you were expecting.
Yes, sir.
Ganesh was thinking some chunk of like chicken piece will come. So it's not. It's a cerebral circulation. Even if a small little vessel will make big change. So small little clot going into putting a perforator, especially of the dominant hemisphere of the left side, could be catastrophic. So you don't look for those chicken strokes. So కాదలొద్దు అండి అయిపోయింది కాదలొద్దు అయిపోయింది. All right. The non-DS is the there is some movement. Perfectly all right. Lateral. Okay, DSA. Cover the head, eye down. Closer. DSA. DSA. All right. Perfect. This looks beautiful. Bend please. Back. Back. Side to side. One more back. So we're very happy about it, and we're going to stop the procedure. So thank you very much for joining us and watching this beautiful procedure, life saving, and thanks from all our team. Namaskar.